everyone. My name is Ariel Hart. I'm a reporter on healthcare with the Atlanta Journal-Constitution. It's been an honor to listen to these wonderful presentations. It's just an embarrassment of riches sitting in the same room. So welcome to the panel on the rural healthcare workforce. And before I start, I wanted to take a moment of personal privilege and dedicate this session to a member of my extended family from rural Georgia who passed away Saturday. Aunt Brenda was a caregiver in rural Georgia, and when she received a bad diagnosis, she needed to move in order to get the care she needed. Her life was extended 2 years because she had family in metro Atlanta, and she moved and lived with them and got rides from them to hospitals and doctors. Her memorial in North Georgia is going on at this moment, and her family's okay with me being here so that all of us can help tell that story. So policy challenges often show up strongest in rural areas. The current workforce shortage is no different. It's hard to imagine an ER in a metro area, any metro area, ever having, going without a doctor for any reason. But this week, KFF Health News reported that 7% of rural ERs at some point in the day have no doctor on site. Here in Georgia, state data shows that 10 Georgia counties have no physician at all. Half have no OBGYN, and I'll show you some relevant data sources at the end of the presentation. And as previous panels have noted, health facilities need to attract these skilled workers in order to be that economic anchor of rural communities. That means providing jobs in the facility and also attracting businesses and other economic activity in the larger community. So our panelists here are some of those professionals, as well as we have an expert who is a former hospital administrator. And let's get to it. I would like to welcome, if I can get to my slide, I'd like to welcome Brock Slabach, who is the Chief Operating Officer, of the National Rural Health Association. And Nikki Bryant, who is a pharmacist and owner of Adams Family Pharmacy and Preston Family Medicine, a clinic that she set up because there was no other provider there. Dr. Sheena Favors, who is the co-director of the Women's Services Program, Albany area primary health care, and serving the main hospital in the center of a rural area of 11 counties. And Spencer Windham, part of the family that runs WindCorp Management Services, nursing homes and family care. And so with that, I'd like to have an introduction from each of the panelists, and we'll start with Brock Slabach. And you cannot see the slides, can you? All right. You know what? Let me do that. I don't think it's going to go over. Well, all right. So, yeah. Why don't you come up here? There we go.
Oh, good afternoon, everyone. And it's a pleasure to be here this afternoon, and thank you, Ariel, for the introduction. National Rural Health Association is a membership organization with over 21,000 people nationwide who are dedicated to providing rural health services in our communities all over the world, all over the nation. We provide all the food, fuel, and fiber that power the country. So if you want to know the why of our advocacy and educational content, it's that nothing happens in this country without the necessary resources that our rural providers are making. These have historically been underserved because payment policy from Washington and state capitals have been somewhat difficult to manage for rural providers because we have low volumes that really we call it the tyranny of low volumes. And that low volume doesn't make efficient services to be able to be provided, and so often there's that disconnect. And so in the area of workforce, we know that basically you can have all the best strategic planning in the world, but if you don't have the workforce to carry out the initiatives that you need in order to improve the health of the communities that you're serving, then it's going to be likely not very successful. And so I work with rural providers as a rural hospital administrator historically. I have experienced these shortages firsthand and the recruitment of of professionals, both physicians, the advanced practice providers, and those who are in the rehab and nursing professions are always in short supply, and it's always a constant need to move ahead with those. The rural health workforce impact, basically going forward, just very quickly, the One Big Beautiful Bill Act, otherwise known as, I'll call it OB3 this afternoon, basically has a number of provisions that are really destroying many of the aspects of what we built in terms of workforce and workforce recruitment going forward. The $137 billion of cuts that came through OB3 are going to be directly impacting provider reimbursements of all styles and shapes. So it's hospitals, clinics, and other services that depend upon Medicare reimbursement and Medicaid reimbursement will be affected. Most importantly, and this was really a disturbing part of the bill, is that it eliminates the Grad Plus program, which is a loan program that was designed for professionals either getting a master's degree or a professional degree, i.e. law, medicine, in the case that's important for us. So that program has been eliminated, but for current individuals in that program, it will continue for the 3-year period that it would be in place. But for those in 26, calendar year 26, it will end for any new applicants to that program. The other notion is that they are limiting the direct borrowing limits for individuals in seeking these professional supports to $200,000. The total will be $50,000 if you include the current year funding. So there could be as much as $250,000 cap on the educational loans that an individual could get for their professional education, in this case, medicine. That is going to be a tremendously difficult thing for our rural communities to overcome, because it's those programs that are able to supply the support for education to be able to take their talents and skills to a rural community and apply them. And so this is going to be, so many people in these universities, in these programs, may have to go to the private market to get loans to be able to help get them through their training. We know that only individuals with resources tend to be able to get loans. And so for those individuals who come from backgrounds that don't have resources to be able to satisfy loan requirements, this is going to be only serving to diminish the capacity of those that aren't really part of the mainstream, if you will, in terms of what normally goes into the educational pursuits. So we are going to see, I think, a rapid change going forward in the education of our rural professionals in general. Then they're going to be depending more on the National Health Service Corps, which is another program, a loan repayment program. You already talked about SNAP cuts this morning, the Supplemental Nutritional Assistance Program. And then so for our rural communities, this is going to be one of the social drivers of health that will definitely deteriorate some of the population's ability to stay healthy. Adding that to transportation and to many other social drivers, that could be really problematic. So that's a little bit of an introduction of what OB3 did to our programming going forward, and how the SNAP cuts and the cuts to medical education funding can be tremendously problematic.
Okay, now we are moving on to Nikki Bryant. If you could introduce yourself and tell a little bit about your arena.
Yeah, I'm Nikki Bryant. I'm happy to be invited here today. I opened a independent pharmacy in a town of 400 people about 11 years ago that hadn't had a pharmacy in 60 years. I lived there, opened my second pharmacy in 2019, and I have a rural health clinic in Preston with my original pharmacy. Graduated from Mercer here in Atlanta, and I'm a current student at Johns Hopkins receiving my master's in public health with a concentration in healthcare policy. So We have a rural pharmacy desert. I'm right in the middle of it in Southwest Georgia. There are currently 5 independent pharmacies serving 6 Southwest Georgia counties, which is about 27,000 people. 2 of these counties have no pharmacy, so out of those 5 independent pharmacies, we are delivering into those counties that don't have a pharmacy at all. So I have 1 pharmacy in Webster County and 1 pharmacy in Randolph County. And I don't know if anybody picked up the Atlanta Journal-Constitution this morning, but there was a picture of Cuthbert, Georgia on the front page, and that's where my pharmacy is. So seems to be that we're dying more than we're birthing in Georgia, and more so in my county. So we service about 15,000 patients in 13 counties out of my 2 pharmacies, and I can tell you it is a tremendous burden to carry that many people and to have that responsibility under the current reimbursement challenges that we face in the pharmacy arena. So if you've ever read, wrote, or talked to an independent pharmacist, we're all just kind of doing what we have to do to make it. So this is a map of Georgia where the pharmacy deserts are. In the green, that's where people have to drive 10 miles to the pharmacy. The orange is 20 miles. The red is 30 miles. So you can see there's a high concentration of where I live. So roles of an independent pharmacist in a rural community are quite different than if you live in an urban area. We face challenges that most do not. I described it to Ariel as an ecosystem all of its own, kind of like the Okefenokee Swamp. And you really can't wrap your head around it until you actually come and see how we operate. We take on a lot of social services because our patients don't have transportation to the doctor. They don't have transportation to their cancer treatments, which are 40, 50 miles away. I helped one of my patients this week with some housing in Atlanta because she has to be in Atlanta for 6 weeks for proton therapy for cancer treatment. So we just do a lot of different things to take care of our patients. And then a lot of younger people in rural areas, they get educated and they move away and they leave their elderly parents with no resources like transportation and home health care and things like that. So we take those people on pretty much as our family, and we make sure that they have the services that they need to survive. So a lot of collaboration of care in our area with other healthcare providers, and when we lose a healthcare provider that is so detrimental, as Dr. Favors will discuss after me, she's in my region, it's devastating because the collaboration of care between providers is so critical. I have pretty much a personal relationship with every specialist that my patients need, endocrinology, cardiology, nephrology, ophthalmology, dentistry, all of those things. I have a doctor in my phone. If my patient is not getting well or their outcomes are not where they should be, I text them and say, I have this patient, they need care, and they always tell me yes, and we arrange the care for them. So it really takes a lot of collaboration to care for rural health patients because there are just so many challenges to overcome that. So let's see. So this is my healthcare team across my 2 pharmacies and my clinic. We have 5 pharmacists, 5 technicians, 3 delivery drivers, 1 nurse practitioner, 2 medical assistants, and 1 supervising physician. And pretty much with workforce, we're very limited. So when we do get an employee, I cross-train them to do a lot of different things. So my technician in my pharmacy also does my medical billing and oversees my clinic. My technicians, I have a bakery in one of my pharmacies just to keep it open. So this morning I got up at 4 and drove in and baked homemade biscuits and had breakfast before I came to this meeting today just to stay open. But my technicians scoop ice cream, they fill prescriptions, they pull espresso shots, they bake cakes. But we just do what we have to do to survive because the pressure to be sustainable is there, and I'm the only one there now. I'm the only pharmacy in Cuthbert, and if I would invite any of you, if you would like to experience Ariel's been down and rode with my delivery driver and got to see all of the dirt roads of Southwest Georgia. So if you're interested, any of you, I would welcome you because it's really a very unique experience. I think that's all I have. Yeah.
I would like to note that Nikki has been active in the controversy between independent pharmacies and PBMs, and one of her quotes is that she can make more money selling a cup of drip coffee than some prescriptions. So next we have Dr. Sheena Favors. Do you need your slides, or do you want to sit there?
Well, I can see them.
Okay, great. Yeah. If you could introduce yourself.
So I'm Dr. Sheena Favors. I'm a board-certified OBGYN. I am practicing in Albany, Georgia. I work for a local FQHC called Albany Area Primary Health Care, where we have multiple service lines. I am a native Georgian. I grew up in Riverdale, Georgia. I trained, I did my OBGYN residency in Far Rockaway, New York, which is in Queens. And I came back to Georgia to be of service to the community. Interesting enough that I am a National Health Service Corps member. I did the Student to Service program once I decided that I wanted to be an OBGYN, which brought me back to Albany Area Primary Health Care, which qualifies. So the National Health Service Corps is an interesting program because it allows you to find areas that are underserved, and each one of them they're given a score. And in order to meet your contractual obligations with the National Health Service Corps, they have to meet a certain level for you to show up. And there's multiple programs. There's a scholarship, and there's also a student to service loan repayment program, as well as other loan repayment programs through the National Health Service Corps. And because I did my medical training in Georgia, I also did my rotations down in Albany, so that's how I found out about Albany. So it's like a little pipeline because we do take a lot of learners, and so that's a way to get them exposed to the rural area to try to drive more workforce to this area. Phoebe Putney is the large regional center in Southwest Georgia. What that means is that they take any high-risk obstetric patients, and that is their location. So we keep all babies 22 weeks and 0 days up to term, and we only transfer them if the baby needs higher level of care or if we do not have the service to provide to the mother. AAPHC, the company I work for, services about 11 counties. And so we get people from an hour and a half to 2 hours away to come to our facility. We just recently had a labor and delivery unit close in Bainbridge, Georgia, so we have a lot of those patients that get funneled to our facility. And last but not least, the interesting thing, fun fact, I was just recently in a docu short film that was premiered at the Tribeca Film Festival called Doc Albany, which features myself as well as Dr. Hotz, who is affectionately known as Doc Hollywood, because that movie was actually mirrored after his life. So he actually, you actually see pictures of him working with Michael J. Fox. So it's fun because I think it was in the 80s, and I'm a little bit younger than that. So anytime I mention it, people are like, "What movie is that?" So we just recently completed that film to bring some awareness to what it's like to work in an underserved rural area.
And am I correct that the National Public Health Service Corps, that is what brought you to Albany, and that's what the Doc Hollywood program
Yes.
was about? Yeah.
So, fun fact, Dr. Hotz was supposed to be in Athens, Georgia, but somehow ended up in Albany, Georgia, and then found that these people who were in this area didn't have any resources, so he took a year and went to Washington, D.C. and worked to help develop a large portion of the National Health Service Corps. So HRSA actually sponsored this film along with Publicis Sapient, which is like the digital platform that it's on. So So a lot of that was just to like bring light to how the National Health Service Corps and HRSA are working together to bring a workforce to these areas that are underserved.
Thank you so much. Okay, and Spencer Windham, if you can sit there.
I'm going to take after Dr. Favors
Alrighty.
and sit if that's okay. Hey, everyone. Thank you all for having us. My name's Spencer Windham. I'm a third-generation long-term care provider. My family or my grandparents started our first skilled care facility back in 1956, the Oaks Nursing Home in Marshallville, Georgia. Funny story on that, we still operate out of that building. That's where my office is. Our WindCorp's home office is located in that building. And my grandparents, when they started it in 1956, it was under the impression that my grandfather would farm and my grandmother would be kind of a stay-at-home mom, and it turned out she started taking in community members that needed care because she was an RN. And from there, taking care of patients seemed to work out better than farming did. And so they began to add on to their home, converting it into a nursing home, and we still operate out of that same facility today, so very proud of that. Our second facility, our skilled care facility that we own and operate is Myona Geriatric and Dementia Center. We've operated it since 2008. Myona is located in Ideal, Georgia. So we've got an 88-bed facility, Myona, that is located in a town with 342 people. I always joke with the residents, we can put a new mayor in office if everybody wants to get out and vote. But they actually have the best compliance record in the state of Georgia. They have 9 consecutive deficiency-free surveys, which I don't know what that's like on the federal level, but in Georgia that's unheard of, and we're very proud of that there as well. For us, and there's challenges all around. It's not only in rural, it's in urban as well, but workforce specifically is the most difficult part of my life. And it was easier 15 years ago when I started working as an administrator of the Oaks. There was more licensed staff. There was more commitment to the employer and to the systems and to the quality that you were trying to produce. The new workforce that's coming in is all about, I want it now, and I want it now. It's not, the willingness is to mold and to buy into systems. The impatience for it is not there like it used to be. So that's one of our biggest challenges is workforce. And obviously in the rural healthcare environment, it's licensed workforce. Georgia is a very, very much a growing state. And you'll see it all over the news about, we want 24-hour RNs in nursing homes. Well, I'll be the first one to say I want that too. I would love to have that. The reality behind it is Georgia doesn't have enough RNs in the state to do that, all right? There's certain states that do, Massachusetts and some others, but Georgia has a lot of LPNs, and certain states don't count that licensure like an RN is. And the reality, if you're working with these individuals, there's some LPNs that can run circles around RNs. And when you know the patient and you know who you're caring for and you know what their baseline is, and when things change, you want that person who's in the building and knows your residents caring for them. So you have to think of nursing homes a little bit different than hospitals in that, in hospitals, you're having patients in and out. In nursing homes, a patient might be there for 5 years. And that caregiver that's consistent is 10 times more likely to do the right thing than that new person that comes in that just has the license needed to take care of that patient that day. So for us, again, it's workforce. I know everybody else has experienced as well, but yeah, that's our biggest challenge.
Thank you so much. Okay, so now I'm going to just do a few questions with the providers and then open it up to questions. So let me start with Nikki. I think the first question I have for all y'all is, What is it like to face a staffing challenge? And so tell me about the workforce shortage from your rural perspective.
Pretty much everyone who, can you hear me? Everyone that works in my clinic and pharmacy has to have some kind of registration or license for the state. So if that person wants to, if my nurse practitioner wants to go on vacation, or if she has a child sick, or the credentialing processes are so complex. Sorry. So it's so complex, and credentialing with insurance and licensing and Georgia Medical Composite Board and protocol agreements. It's so complex that you can't have somebody just sitting around with all of that done waiting for my nurse practitioner's child to be sick. So when she's out, we're down. We can't see patients. Pharmacy technicians and pharmacists all have to be registered and licensed with the state. So that's what I was saying earlier. We have a lot of employees. Most of them are cross-trained to do multiple jobs so that we don't have to carry extra payroll or find someone that's qualified, just standing around waiting for us to call. So that's the biggest challenge that I have is I always try to plan for a vacancy. So there are some situations where we have to move our employees around. I have multiple facilities, so we'll pull a person from one pharmacy and move them to the other one or the clinic. But all of my employees are very flexible. They know the challenges that I face running these facilities, and they're willing to do whatever I ask them to do. So if we have a delivery driver out, somebody steps up, one of my techs says, I'll do the deliveries today, or I'll bake the brownies today, or I'll do whatever you ask me to do. And they respect me, and they're very loyal. So I have a great team. But when we're down, we're down.
What do you do if you need a new pharmacist?
Well, I was waiting for a pharmacist to graduate last year. So I waited for her. She started with me when she was 16 years old, working on the weekends. She went to college and lived with me for a while during college in my home. And then I encouraged her to go to pharmacy school, and she did. And I had a 75-year-old pharmacist waiting for her to graduate. It was just me, him, and one technician running my pharmacy and my bakery and coffee shop. So I had to wait it out. And when she graduated last year, she came on board full time, and my 75-year-old pharmacist decided he didn't want to retire. So he's still with me. But it's in a rural area, we don't have a lot of things to offer for young people to draw them there. I mean, you have to drive 40 miles to Walmart. You can't just run into Target. It's just, it's very challenging to make that kind of lifestyle attractive to young graduates. And so I think the National Health Service Corps, we used to have that program for pharmacy when I graduated, but we need to bring it back.
Thank you, Nikki. Dr. Favors, can you tell me what's it like to face a staffing challenge? And I think you've dealt with that in the last week, am I right?
So another hat is I'm also serve as the co-clinical director of the Women's Services Group at AHCJ. So one thing is you wear multiple hats. But fortunately, I have 3 full-time partners that are OBGYNs. I have 3 midwives. I have a couple of PRN docs that come in and help out from the Atlanta and actually Florida. They drive up for that. And I have 2 nurse practitioners. So I do have a very solid team. The issue is that it sounds like a lot of people, but when you're seeing almost 1,000 patients a month, that's not a lot of people. And then if one person gets sick or their child gets sick, or one of my poor midwives, she's having hip surgery, so that puts me down to 2 midwives. We're covering call and we're covering the office. So if you say that's 5 people, you have 60 shifts in a month. You're trying to figure out how to cover all of those shifts. And there are 12-hour shifts. So that's kind of hard to figure out. It's not like I can pick up the phone and be like, hey, can you come work today? They have to have a certain skill set. or like if somebody has a family emergency and they just have to leave, we have to figure out how to pull that call. That may mean canceling patients for that day, so that provider can be where the acute patients are, which is at the hospital. So it's a constant juggling act. It can overburden the system at times, because if someone's out and someone has to take on their patients, that provider may already have 25 patients scheduled, but now they have 35 because they took 10 from this provider and then they split in, the other provider took 10 of the other patients, just to try to get the patient seen, because we know that if that may be the day that they can make it to the doctor. That may be the only time that their cousin or aunt or someone can drive them there. We've just had a lengthy discussion about like transportation. That's a huge issue in a rural area. And so you try to catch a patient when they're available, so that way they can get care, because if they're deciding between going to work and paying a bill, or do they have gas money, they're going to pick going to work. I hate to say it, they always do. They always pick going to work. They'll tell you, I can't come to that appointment because I have to go to work. And even if they're in the most dire straits, they will pick that job. Because they're thinking about how they're going to keep a roof over their head, or how they're going to keep gas in their car or food on their table. So their health care kind of falls by the wayside. So by the time they encounter myself or one of my partners, they're in pretty bad shape, and we're trying to undo things that may have been progressing for years, or in a pregnant patient, months that we may have not caught until late in the pregnancy because they couldn't get care early enough. So, not having the workforce is a big deal for access.
And Dr. Favors, I wanted to ask you, I saw a figure before the panel that somewhere between 1 in 20 or 1 in 25 rural households, not individuals, but households, have no access to a car. Does that track with what you've seen?
Yeah, so we have a large Medicaid population, and they do have services, but those services are limited because there's a time frame in which they have to book those services. So let's just say a patient does get to my office via Medicaid services, and then I say, hey, you need to go to the hospital because your testing in the office is abnormal. Now they don't have a ride, because that Medicaid service is, they're saying I'm taking you from point A to point B. Point C was not in the agenda, so we have to figure out how to get you. So I either have to figure out a way to get some prior authorization thing on the phone, which is kind of a tedious process, and especially when I have a waiting room full of patients. They want to speak to the physician or the provider to get this approved, and that's if somebody picks up the phone. Or I have to call the ambulance. So, and if you're living in a county where there's only a few ambulances, you want to call the ambulance for a non-emergent case because the patient just needs to get to the hospital. And rideshare, it's an option that's out there, but it's limited in a rural area because how many people have cars to even perform the service for rideshare? So you're kind of stuck between a rock and a hard place. And as a facility, as an FQHC, you're trying to think of how many services can I provide to decrease the number of barriers that you realize that all your patients are experiencing. So.
And one last question for you, since we're talking about challenges. I'm hearing a lot about the extra time that you have to spend doing this, that, and the other. We've heard a lot about national changes recently. One of them that affects your area of practice is Dobbs, the abortion decision. Does that affect your schedule at all?
I won't say scheduling, but I will say it does make it take longer, I guess, because things you've been trained to do, and training is really rigorous for a reason, so that you can learn to make those decisions quickly. But when you're thinking, and a lot of times you're not always thinking about the medical legal portion of it, because certain things weren't an issue when I was training. Things like things that were considered things to perform an abortion are also things that you use for somebody who has had a loss, not necessarily for somebody who is trying to have an elective termination. So those are all things that I'm thinking like, okay, well, what do I have to wait to happen before I can intervene, so that this isn't seen as I'm making a decision to terminate this pregnancy outside of the Georgia law. I've given medicine where I've had pharmacists call me and ask me, is the patient having a miscarriage? Like, do I have it documented that the patient is actually having a miscarriage, because that medication is known to be an abortive agent. So it's extra steps, so it delays the care. And at some point, the delay in care may cost someone their life. So that is the balance. You know, you have to decide whether you're going to, and I always say, take the L. You're going to be the person who's going to get in trouble or potentially have to get called on a red carpet for making a decision that may keep that person alive. And that's a hard decision because that's not what I trained to do. I didn't train to like think about which legal parameter I need to take. I trained to take care of people.
Thank you, Dr. Favors. So, Spencer Windham, can you talk about looking at the health force challenges? What's it like for you to face a vacancy? Like if you need somebody who's really got that high skill level, if you have to have that person, what's it like to face a vacancy?
I think, well, first, I think you pray. I mean, I think in order to be in the healthcare industry, you've got to have a strong faith because there's days where you want to pull your hair out. But getting creative is always, when we have significant vacancies or we're going through a workforce challenge, our team looks at what are employees actually wanting. Is it a different schedule? Is it less hours? Is it more hours? And so we get creative on shifts. We get creative on dates. And I always tell individuals, you're either fall in one or two of the three categories, either job responsibility or pay or schedule. You can't have the best schedule and the highest pay. You can't have the easiest job and the highest pay. But you can have the most difficult job and the highest pay, and you can have the most difficult schedule. So for us, as long as we're able to identify what areas that person motivates them, we normally have a good system for hiring and keeping and retaining. But we do things like we set up our own, we have close to 200 employees. And so we literally have vacancies every single day. If Indeed would give me free advertising, I'd have about 20 advertisements for both facilities going on all the time. But that's not the case anymore. It was at one time. But we do things like nurse aid training program where we'll have, we're an on-site CNA training site. So they'll do all their skills, all their exam checkoffs, all of that at our facility, all of our clinicals, and hopefully after they get their license, they'll want to stay with us. We pay for that for the CNAs rather than them having to go pay somebody else to get licensed. We invite technical colleges to come into our facilities to do their training, to do their clinical work, so they can get an idea of what long-term care is, what nursing home is. I think most of the people, when they get into nursing, they think hospital and they think, that's where the fun is. Us having the ability to get in front of those students and let them see nursing homes is not just where, mom and dad go when they're a little old and need a little help. I mean, we have residents with trachs. We have residents that are bedbound. We have residents with memory care needs, tube feeders. Nursing homes 20 years ago is not what nursing homes are today. Rehab, occupational, speech, physical therapy, all those things are combined under one roof. So it truly is skilled care services. And when we're running into right now we're evaluating doing a daycare at one of our facilities because in a rural market, when the school shuts down, you lose all your staff that day because they've got to take care of their kids. So we've tried to get creative and say, okay, can we just get a part-time nanny so we can put out in front of our facility? We have a nurse aid training class when that's not going on to allow them to help watch some kids so we can stay staffed. So you just got to get creative.
And you had told me about the program that you've got, and I also, because we mentioned like the larger economic impact of these places, what does your workforce mean to your county when like the power goes out or there's a storm or disaster?
Sure. So, in rural Georgia, healthcare, and this goes for hospitals and in nursing homes, if you're not prepared, your nursing home can be a liability or it can be an asset to your community. And both of our skilled care facilities have automatic generators that will run heating and cooling, our kitchen, our freezers. We are an asset to our rural communities when the lights go out. We have community members coming to us to eat at our facility. We have community members coming to our building to take a warm shower. So if you have a rural health care and you don't have a generator that's automatic, that can power you worth of 7 days of AC, that's not with the storm systems we have today, that is not just a need. You have to have it. There's no question about it. You have to have it. Because what then happens is you turn into a liability when you don't, and the community then has to help give you resources to either evacuate residents and help you kind of limp along rather than you being able to support them. So we've seen that be a great asset.
Thank you so much. So I'm going to combine my last two questions so we can hopefully have time for audience questions. What is a time when you were facing a workforce shortage and you overcame it? You overcame in general, as they say in the South. And if there's one thing that you could change or anything that you could change, what would it be? And let me start with Nikki.
So I think I was thinking through the challenges that I faced, but one in particular, I had a patient who was in her 8th month of pregnancy and came to me and she said, "Nikki, I'm just not comfortable with my provider and I don't know what to do." And, they didn't teach us that in pharmacy school. But, I said, "It's going to be okay." I reassured her. And then I got on my phone and I text one of my gynecology colleagues. And I said, "I have this patient. She's in her 8th month. She's about to deliver. She's not comfortable. What do we do?" And he said, "What do you mean, what do we do? You send her to me and I take care of her. Like, why are you even asking me?" And I know Dr. Favors would probably agree, but there's not a lot of physicians who in that field would take an 8-month-old an 8-month pregnant person. It's just not heard of, but that's the kind of thing that I do all the time. But if there's one thing that I could change, it's PBM reimbursement reform. They have totally destroyed my industry, my profession. They're the reason why I have to bake biscuits every morning. The reason why I have to struggle to pay my drug bill and to make payroll. So if there's anything that is most important about the survival of pharmacy in this country, it is that. So.
Dr. Favors, can you tell us about a time when you overcame something related to the workforce shortage, and if there's one workforce thing that you could change, what would it be?
So about 3 years ago, pretty much everybody in my practice left. I mean, for lack of a better word. Like, I literally was the only person that was still under contract. My partner that I still have now, we convinced her to come back, was going to another practice. And at that time, we changed a lot of things. There was a lot of changes. And we started covering the hospital ourselves because for a long time, the OB/GYN department couldn't support itself in a sense. And so we were taking call, my partner and I, we were taking call every other day. So we would come to the office in the morning and then we would take call at night and then we would start the next day on call and get off at 7. So it was like reverse 24s, and then so that person could be in the office until we could get some help. And we did that for almost 6 months. We did have locums, but when you're not really supporting yourself from the beginning, like that service line, and you're getting locums is very expensive. Like it shouldn't be and people think that the money goes to the doctors, but really the conglomerate that is locums takes a lot of that money, and it's a big burden on systems because they're very expensive. So we decided to create our own PRN pool. So we got doctors who didn't really necessarily want to be in the office full time, but were able to help with the call burden. And we kind of made our own locums pool, and they would, so we just had to figure out a way. We did that with the midwives so that the midwives could have a break, because I had 4 midwives One of them left. One of them got in a horrible car accident and lost her spouse and had to go back home. Like, so it went from 4 people to 2 people very quickly. So we had to find people who could work as needed. So we just tried to figure out a way to overcome that shortage. And luckily we come out on the other side, because if we didn't do that, the OBGYN service would not exist. If there's something I would change, transportation. So as part of the social determinants of health, like transportation is probably at the top of my list, because if you can't get to the doctor, you can't get to the store, you can't get to a lot of things. And then unfortunately in the rural areas, there's very limited public transportation. In Albany, we do have a bus system, but it's extremely limited, to where we even have mobile units to try to help alleviate that, to go out to these communities. And unfortunately, the building's not going to move. So because rideshare is difficult and also in these areas, it would be nice to kind of internalize that and have your own transportation system, which if anybody finds out a grant, anything like that, let me know so I can, get that working, because I just think that if you could eliminate at least one of those barriers, we can work through the others. Like, we can work through the food shortage. We have some things in place to help that, but if I can't even get the person there, that's the first step. So I think I would try to come up with a transportation program for my facility.
Thank you so much. And when you were talking about locums, I'm guessing it's locum tenens, the basically temp workers in the health field.
Yes.
And I guess I should address the question, why can't temp workers solve the problem if you are missing someone? And I've heard that basically they can be double the price if you can even get someone.
Yeah, they're quite expensive. And then when it comes to patient care, continuity is everything. Like, I think a lot of stuff has gone to shift work because it's such a difficult field to be in. You're constantly on. Like, it's very easily to work 180 hours. Like, it can get very, very, very tedious. So I get there's a place for it, but when you don't know the patient, especially when you were dealing in a high-risk community that Albany is, these patients are quite sick. One, is a liability issue, but 2, it doesn't service the patient, because now the patient is not intentionally not getting the best care, but they're getting what they have available to them. Versus, I think there was a slide up there. We took over our own patients in the hospital, and we lowered our C-section rate, our primary C-section rate, which is kind of there's something that's like on a national, they look at that. Our low birth weights have decreased. It's just simple things about knowing the patient and knowing what they're going through that helps you make better informed decisions for that patient, versus someone who may be just traveling in from Minnesota. No offense, Minnesota, I just picked you.
Thank you.
That may not, that they're not vested in what they do. They just don't know the patient. So, they may make a different decision.
Thank you, Dr. Favors. So Spencer, last but not least, what is the time when you overcame a workforce challenge, and if you could change one thing?
Okay. Obviously, and probably everybody, I'm sure everybody in the room was affected by this, but for us, I immediately kind of go to COVID. We went through a time where we fought it, where we're not going to have it come in, and we then realized there's no other way it's going to come. It's not a matter of if, it's a matter of when. And when you have to get in front of a staff of 50 and 60 people who are crying because they've already lost a loved one, and let them know that, hey, it's going to come in the building one way or the other. There's no way of not at some point getting exposed to this. That was difficult for us, because we lost probably 25 to 30% of our workforce within a few weeks, just because if you were in a situation where you were thinking about retiring, like, you retired. That's not the way you wanted to go out. And so we were able to navigate COVID without using contracted staff. And one of the ways we were able to do that was, we incentivized our housekeepers, our dietary, our anybody willing to do it to get their CNA license, and or become a TNA, a temporary nurse aide, which helped us allow that person can then help with transfers. They could help with feeding. They could help with different activities of daily living to allow for us to provide the care that we had to either way to our patient population. So that just immediately comes to mind. I mean, of course, the CNA program that we implemented, 12, 13 years ago, we've probably produced in our rural area hundreds of CNAs, which is, some stay, some go, some come back. So that's always been good. But, one thing I would change, I guess, and there is a tendency now to, you want to make your own schedule, you want to work your own hours, and you want to work your own shifts. And that's the place for temporary staff. And unfortunately, in the healthcare settings that we're operating in, it's really not a good place for us. It's not a good place to be an employee into. And it's just because the outcomes are not there when you have the consistency and when the caregivers know the patient and they know the baseline and they know when they come into a resident's room and they say something is not right with her yesterday, she's never done this before. That person that's coming in there for the first time might think she does this every day. And so I think that's what I would change. And the awareness that, one, we obviously need more licensed staff in the state of Georgia. We need more LPNs. We need more RNs. I know there's a couple of programs right now. I think maybe UGA has one to build a nursing school and a few others. But so yeah, the state we need more licensed staff.
Thank you so much. So those are my basic questions. If anyone has a question for the panelists, please.
Hi, thanks for being here today. The Georgia legislature in the last couple of years has passed a number of bills attempting to address this healthcare crisis in Georgia. Those include streamlining licensing, especially for people coming from out of state, attempting to, in a small way, increase reimbursement rates for providers, and very targeted service loan repayment programs for people that work in specialties and in certain geographic areas. Have any of those made any meaningful difference in the workforce in Georgia for healthcare?
I don't mind speaking of that. Yes, every little bit helps. We've, as recent as I believe it was 3 years ago, something was implemented called certified medication aids, which allowed for another tier of licensed staff to be able to administer meds in skilled care facilities. Obviously, with the Medicaid population that majority of nursing homes have, anytime you're rebasing to cost, whatever the cost you are that you're spending, is good. And our legislator has done a great job of making sure they're at least trying to get close to the cost that you're spending. You haven't quite gotten there yet, but yes, there has been some improvements in that side.
What about either Dr. Favors or Nikki? Have you seen any results?
I will say that the licensing it has improved. I feel like it may be more of a workforce thing on that side of things than it is like, yes, this thing is implemented, but I'm not sure if they have the bodies to make it go faster, because I think when I got my Georgia license, it was pretty quick. But I did have a newer provider in the office that she literally was at work for an additional 3 months before she could really see patients, like, because credentialing is a whole nother beast, like enrolling in all of the different programs, and we take everyone, so you have to be enrolled in every healthcare plan. So I think it's more of a workforce based on the other side, like, to handle that, than it is more like, yes, the initiative is there, but if you don't have the bodies to make it function, it doesn't really work that well. So a lot of times the FQHCs, they kind of get reimbursed a little bit differently. So I will say that that's helpful than, maybe being like what they call like a point of service reimbursement rate. But in comparison to other states that may have expanded their Medicaid and things, we're not close. Like, it could be better, especially with the cost of medicine these days. Like, the cost of medicine kind of outruns what we're actually getting back.
And Nikki, have you seen any state programs that have resulted in, bodies, workers being able to come to you better trained, or more of them who are trained?
Yeah, I'm very active with policy and bill pharmacy reimbursement reform, and I think that we have a very important piece of legislation that was signed by the governor that will go into effect on January 1st, increasing reimbursement rates for state health benefit and university system plans, which it's a trickle-down effect, because when we get paid fairly and we get paid enough, we can pay for staff and we can employ enough people to take care of our population. So a lot of bills that have been very helpful with that help support employment.
Thank you. Question over here?
Yeah, so it seems like one of the big through lines of this conversation is is about workforce shortages that exist. And I guess my question, I wanted to pose it to Brock, just to understand, I guess, the uniqueness of this situation. Is it like more of a contemporary moment, or has this always been like a feature of rural healthcare?
Well, I think the through line is exactly that. It's been something since time immemorial. And if you have all of the parameters that were discussed in terms of attractiveness of moving to a rural community and attracting someone to move there, I think what I would say, if I could change something right now that would help for the future, it's not going to be immediate, is the Affordable Care Act in 2010 authorized the National Healthcare Workforce Commission, which was never funded and stood up. But we do not have in this country an accurate and vital database of professions, the number of people in each profession, where they're located, where the shortages are, and what are the policy levers that could be tested to see what works in moving people to places where there is need. And we don't have, and this is rural and urban, this isn't just a rural program, because we have workforce shortages in urban areas as well. So this isn't unique to rural exclusively, although I think it's more intense there. But I think that we have to understand better. You know, you mentioned several solutions. Well, we don't know. How are they working? Are they not working? How do we evaluate that, and who's doing that work? And that's what I think we need if I had to change something. And this has been going on for quite a while, so it's not new, but it's more intense now because we have such significant shortages that we've not seen that we have at the moment.
And so these data sources that I have posted up here, like I know with the Georgia database, they're just pulling that from the number of people with a license who there's nothing pure.
No analysis, it's
Right.
pure just data, but what are the policy levers that would be useful?
And are they providing
And are
care,
they
and what
working?
kind of care, right?
Yeah.
Karen?
Thanks for the great panel and all the great presentations. With immigrants such a big part of the rural workforce, I'm really curious how you are all seeing the new administration's approach to our immigration system play out in your specific domains.
Thank you, Brock. Brock has to leave, but I can connect you to him if you need to. I guess anyone who'd like to answer, I know that I've spoken about this with Spencer.
We have a lot of migrant workers in both of my communities, and people are people to me, patients are patients. So, when they walk into my pharmacy, I don't know their citizen status, or I don't really care. I'm there to take care of them. So, if they're uninsured, we help with that. If they need help with compliance, or if they need help with getting into a specialist for oncology or cardiology, or, it doesn't really matter to me where they came from or where they're going, or if they're here and they're not supposed to be or not. They're my patient. So,
But yeah, like what, so let me ask you,
Workforce-
Nikki. Yeah, so I talked to a nursing home in Metro Atlanta that had 35% of their workforce was immigrants.
Oh, yeah.
And so, like, how does that pan out in the employer side? How many, like, is that?
Everybody has to be registered with the state to work in my pharmacy. So you have to have background checks and fingerprinting, and so it's very regulated who can have access to prescription drugs. So we have to validate their citizen status to have them registered with the state. I currently do have a Hispanic technician. I love her, and she speaks Spanish and knows sign language, and she's a vital asset to my pharmacy. I don't know what I would do without her, but I think employees, as long as they meet the qualifications that the state requires, then I loved having them on my team.
So, personally, my facilities, I don't anticipate any effect by any policy, but I have spoken with other owners who are concerned because, as you mentioned, I spoke to the same individual you did that says they have either 35 or 35% of their employees are immigrants, and you can't teach always work ethic. They're there because they're great workers, they're great staff members, they're great community members. So I do, I've said it before with George, in the different boards that I'm on, I would love for there to be a program for nursing homes to be able to bring in some individuals who do have the work ethic and want to, work in long-term care and work and provide quality. It is not just it's a job you get purpose out of. And I think if we can attract those individuals who have the work ethic, I think any program I would be interested in that they're willing to do that.
And Spencer, when you and I were talking about this, I asked you, what would you do if somebody came for those two employees?
It would be a fight, a big fight. I've got two of our employees who, and again, I don't know the background. I mean, everybody goes to the same licensing, and two of them are best two staff members, best two caregivers, and one is just simply work ethic. I mean, we talked about this before, and getting creative. I had a CNA who is working two jobs. She's working at our facility, and she's working at a facility down the road, and she's our best CNA, and I'm like, why are you doing this? Why can't you do all your hours with us? She says, well, I need two jobs to make it. And I said, that's fine. You work with us 2 shifts, and I'll give you whatever days you want off. You work 2 days, off a day, 2 days off. And it was something that just was a blessing for her, a blessing for me, because I get all of my, great staff member, and the residents get her care. But sometimes it takes getting on that level and asking those questions to really get to the bottom of what the problem is. And I think you have to be willing to do that as an owner.
Well, all of y'all, thank you so much for being here. I just have really enjoyed this.